Thank you. First of all, I want to thank one more time Manos and Manos for inviting me. And on behalf of the French Arthroscopic Society, it's a really great honor to be here and to be associated with this meeting. So the topic is how to deal with a subscapular in 2024. If we look at the anatomy, there is nothing new since 2008, and we all know that there is 3 parts in this tendon. The first part with the upper part, which is a round, wide, and strong tendon, the middle part, which is a flat tendon, and the lower part, which is a muscle part of this tendon. However, GD reported recently in 2022 that this muscle part, which is the lower part, is quite different than the other part of the muscle, and it is not inserted in the same place, but on the pillar of the scapula and not in the fossa, and it may be a part of the subscap minor regarding functional and innervation point of view. If we are speaking of subscapular, we need a classification system, and have to promote this French arthroscopic classification system, which is really useful, reproducible, and easy to use. It is based on the analysis in axial plane, and the type 1 is a partial tear of the subscap without any involvement of the medial wall of the groove. The type 2 is a partial tear with an involvement of the groove, which is responsible of instability of the biceps. The type 3 is a full thickness tear without any retraction of the tendon, because the continuity of the transverse humeral ligament. And the type 4 is a full thickness tear with a gamma sign, as you can see here on the picture. The beauty of Lafosse classification system and either this algorithm is that the analysis is in the axial plane, but in the frontal plane as well, and it helps you and guide you to perform an adequate repair in box or out box. If you have a type 1 or type 2, it means the one upper part, one-third upper part of the tear, you can do an in-box with single stitches and single anchor repair. If you have a type 3 or 4, you need maybe a double row and multiple anchors to repair this tear. The crucial question is, do we need to repair a type 1? This is a typical example that there is an intact groove, as you can see here on the video, and we just have a partial deep side tear, as you can see here. I'm not sure that, according to the literature, it is proved that it will improve in post-op results of the repair. The second question is, do we need to do an outbox repair in case of type 4? It means full thickness tear. I will prove you that it's possible to do an in-box repair, but step by step, as you can see, you need first to release outside the box, from the box, the anterior compartment. The first step is to release the lateral border of the conjoint tendon and go as medial as possible, but you will see that you are locked by the brachial plexus, but you need to release all this soft tissue. If you have any question regarding where is the brachial plexus, just use a cautery and you will identify where it is in a few minutes. Now, when the anterior release is performed, you go inside the box and you will release the capsule in between the upper border and the round tendon and the glenoid. You must go medial, but close to the bone. It's safe. And now, once done, you go up around the round tendon and you open the rotator interval. And then the release is quite properly performed, and you will see that you can pull back the round tendon onto the lesser tuberosity very easily. The next step will be the repair. Sorry, go back. Yep. Here we go. And you need maybe a couple anchors. The first anchor is for the flat tendon. So you do a single stitches at the deep part of the tendon. As you can see here, it will help you to reduce and stabilize the reduction. You should use double-loaded anchor, as you can see here. And it will really easy to pull back the flat tendon. Then you will use the flat suture, as you can see here, and you will retrieve the two flat suture through the tendon. So this is the first step, first anchor for the flat tendon. Then we'll go on with the second anchor for the round tendon at the top of the footprint. So more or less the same technique. You put an anchor at the top of the leather tuberosity and one single stitches for the deep side of the round tendon and the other one with the tape through the upper part of the round tendon. And then you will do what you used to do, I mean, just like speed bridge repair. You catch the four suture, and you use what is the strong part of the head. I mean, the groove, as you can see here, to use a knotless anchor, and now you have done a very good repair. If you have any question regarding the reduction of the upper part of the subscapularis tendon, you can use the middle glenohumeral ligament test, which was promoted by Laurent Novy-Josserand. If you pull on the upper part of the tendon, you can see that the glenohumeral ligament will come back at the anatomical place. It's an indication for repair because probably that the upper part of the tendon is retracted, and it can help you to find and to identify the good position for the repair. I would share with you the principle that Komasan need to be kept and not to be cut, just because when the tendon is repaired and the Komasan is fixed, you will see that the next step, which is the repair of the superior cuff, will be really, really easy and obviously reduce, just because the Komasan helps you to fix the anterior part of the posterior superior cuff. I did not have this experience, but Alex, my friend, reported that you can reinforce the upper part of the subscap with the long head of the biceps. So French surgeon and Swiss surgeon are not always biceps killer, but biceps user, as you can see here. So this is an option. I don't have any experience. I will see in the future if it will help the patients. But the next question is how to do in case of non-repairable subscapularis tear. What does it mean? It means that you can see that the fatty degeneration is above stage 2 and the tendon is retracted. Well, go back on clinical presentation. According to me, this is the basic of my indications. First, you can see that the patient is really painful. It can show you where is the pain. It's anterior of the shoulder along the muscle belly, and you can see that on CT scan, ultra CT scan, there is really pathology of the bicep which is dislocated. And if you look at inside, you can see this kind of bicep which is delaminated and stable in medial. So for this kind of patient, which is retired, no high-demand, maybe you can do what I call the weaning procedure, because it's a very quick procedure without with local regional anesthesia, maybe one day an office procedure, an office surgery, and it helps the patient for pain. But if you look at this second case, the patient has full range of motion, but is complaining of loss of internal rotation. As you can see, he has a positive belly press test and a positive bear hug test. And if you look at the CT scan, no arthritis, but the long leg head of the bicep has already been done. And he has no option to repair the subscap. So according to me, the first option is to do a PEC minor, the second would be a PEC major, and the last one would be a lat dorsal transfer. Lat dorsal transfer, which is really new in our box tools, is to translate the lat dorsal as high as possible in my hands on the laser tuberosity. I don't have any experience to do that arthroscopically, but some of you in the rooms has. And if we look at biomechanical models, you can see that if we compare the native subscap to the other type of transfer, the lat dorsal is winning because it's really close in anterior rotation regarding the moment of arm in adduction. Same thing in 90 degrees of abduction. And if we look at now the moment of arm, it's stable from neutral to anterior rotation with lat dorsal, which is not the case with pec minor and pec major transfer. So I would say that in case of painful functional shoulder with loss of anterior rotation, if the patient is young with non-repairable subscapular, no arthritis, no stiffness, maybe you can use a lat dorsal or pec major transfer. However, if we have a patient complaining of anterior shoulder instability with apprehension, which can be the case in case of revision of failed anterior shoulder stabilization, multiple surgery for anterior shoulder instability, well, the lat dorsal seems to be better than pec major transfer. And the last situation is quite different animals because even if the patient looks young, he has a pseudoparietic shoulder, as you can see, with no more active abduction and anterior elevation. He has weakness in anterior rotations, and it's a pseudoparietic shoulder. And in my hands, in my mind, there is no other option than to propose a reverse shoulder arthroplasty. So thank you for your attention.